Well, here we are, Renee, another episode, and this is an exciting one this time. Tell us why I'm excited.
Well, I'm excited because we've got an amazing guest with us today. Is a good friend of mine, and we've referenced her I don't even know how many times on this podcast. So she gets to come and chat with us today, and I'm so excited. How about you, Jason?
I am excited. I know Leslie's ears must be burning because we do talk about her a lot, and reference her in other podcasts. So I am looking forward to this conversation.
I am too. But before we get started, Jason, what's happening on the farm? Anything good?
You know, the grass is growing, and when the grass is growing, you have to mow your yard like a couple of times. And when you got
Yes.
a farm, you're weed eating, and so it's just hard to keep up on everything. And I just feel like that's where we're at in the summer, which is good. Grass is growing, means the crops are growing, everything is looking great. And so
That's right.
I guess I have to complain. So, I want the grass to slow down just a little bit, but not too much.
There you go. That's perfectly good farmer complaint. A little bit, but not too much. Well, today's show, we're really excited because we have Leslie Carpenter here. I'm going to introduce her in just a second, but we're going to talk about some things called assisted outpatient treatment. We're going to talk about decriminalization of treatment for people with serious mental illness, which is one of my favorite topics. And we're going to also talk about housing that heals, which is one of the other favorite topics that I have. But let me just give you a little background on my connection with Leslie. I don't even remember how many years ago now we've met when I was a legislator at Capitol, a long time ago, and she started advocating, and she'll tell you her story in a minute, but she's got an adult son who suffers from severe mental illness. And she started just coming to the Capitol and advocating and advocating and advocating. But what I loved about Leslie is she wanted to know how to do it. And so she kept asking questions about, well, how do I do this? And so I basically just taught her how to be a lobbyist and said, do it. And then you quit your job and became a lobbyist and just did it. And it's been amazing to just watch that whole process go. And now you're at the Treatment Advocacy Center. So we have so much to talk about today. So Leslie, I'm so excited you're here. Welcome, and just give everybody an introduction about you and your background and why you're joining us today.
Sure. Thank you. And thank you both for the invitation to be here today. I'm excited. You guys threw that word around, but I am excited to be here. And I do want to say I've been listening to your podcast and been enjoying the conversations along the way. So I am a retired physical therapist, and I retired in 2019 when I recognized, after having tried to help our son, who has a very severe schizoaffective disorder, recognized all the barriers we face in trying to get him care and all sorts of different kinds of care, right, across the system. So eventually became involved with NAMI, Iowa as well, and started advocating as a citizen, and then did become a volunteer lobbyist. I'm probably fairly unique in doing that. But I am grateful to you, Renee, because you did teach me a lot about the logistics on the website, but also the logistics of how to do it, right? So over the course of time, I've gotten involved in doing a lot of teaching, a lot of advocacy, and I do work for the Treatment Advocacy Center now on a part-time basis, tracking legislation across the country. And that's exciting too. But I want to say today, talking with you, I'm wearing my Leslie Carpenter hat and not my Treatment Advocacy Center hat or my NAMI Iowa hat, just because that's an important thing to announce.
Yeah, that's really fair because you do have a lot of hats and you're not really lobbying today. You're just telling me what it's all about with your personal life. And so thank you for that. But to get us kicked off, there's a big word that I don't know how to say very well, but I'm going to give it a go. And you're going to tell us what it means. Anosognosia. What is that word, Leslie? And how does that play into what we're going to talk about today? Give everybody kind of a primer of what does that even mean? And then that kind of gives us a big picture of what we're talking about today. So what is that?
Absolutely. So anosognosia is something that happens with a fair number of people who have a severe mental illness, especially people with schizophrenia and schizoaffective disorders. It is where they have some changes in the frontal and parietal lobes of their brain as a part of the brain illness itself, and it makes them completely unaware of their illness and completely unaware of their need for medication and treatment. And it's actually one of the big missing pieces in terms of our policy and how we approach improving the mental health care system. If we don't take that into account, it is something that we're missing in terms of solving the problem, right? Because actually, the mental health care system works pretty well for people who know they're sick, right? We have access centers, we have hospitals, we have outpatient doctors and therapists. But if you don't know you're sick, it increases the challenge of getting that person to care exponentially, right? And so it's a big piece of the work that I do. And it makes it challenging because our adult son had a lot of anosognosia. He did not know he was sick, and it's present both when somebody's in an acute psychosis. So like when they're thinking they're God, they're, a higher being, they don't think they need medical treatment. They think they need to go save the world. So when you start talking with them about taking medication, it sounds bizarre to them and it makes no sense. And there's no way they're going to cooperate with that. And it also is present in a fair number of people, even after they're stabilized on their medication, that they still don't see that correlation between being able to stay on the medicine and stay out of the hospital or stay out of jail, as the case may be.
Yeah, I love having a term to put with that, Leslie. And it's unfortunate we don't hear that term more often because it really helps define how we should all probably be working together across the system. So why don't you talk to me a little bit about how important collaboration is? As we think about working together, teaming, case management, it just doesn't feel like that we're always pulling in the same direction.
Yeah, I love that. And I absolutely agree with the idea that we need communication, collaboration, and cooperation. You guys have been speaking to that across your podcasts, and it's really true. And it's one of the solutions that doesn't cost any money to implement, right? It's a matter of changing the attitudes of the providers. And I want to talk about a term called learned helplessness first. And I'm sure you guys have heard about that in terms of the patient. If somebody's hospitalized for too long, they kind of learn to be helpless. And I've certainly seen that with our son and others that we've encountered. But to us, another portion of this problem is that a provider of mental health care in hospitals and outpatient agencies, I think a fair number also develop a certain amount of learned helplessness, right? They throw up their hands and they say, we're so sorry, there's nothing else we can do. Instead of picking up the phone, making that warm handoff connection for where they know that person really should be getting referred to get their care, they just kind of say, nope, you're going back out onto the street. So, there are excellent examples where this is improving. In Johnson County, I serve on the Systems of Care Committee, and we're getting together people from the hospital, from the outpatient mental health providers, the mobile crisis, community response, the shelter house. We're getting all the players in town together, and we're developing those relationships to be able to do that intensive case management of the people who are going through the revolving doors way too frequently, and putting our hand up and saying, nope, that's the 22nd time this person's been back to the ED. Is this working? No, we need to figure out, let's keep this person a little longer and let's get this person to a residential care facility for a period of time. That's the kind of thing that we need to start doing everywhere.
Yeah, I agree. I hadn't thought about it from a learned helplessness perspective, but Jason, you're working in another state right now. And if you think about what we just talked about kind of becoming before we came on to record, that's exactly what happened in that state, right? They're stuck in like 40 years ago and they're saying, well, there's nothing we can do, and threw their hands up about the entire system. So it sounds like this learned helplessness is not just patients.
I was just thinking about that. Systems do the same thing, right? We literally just had the conversation that the entire system just gave up and everyone's just stuck, right? And when everyone gets stuck, then that just backs up not only the system, but it keeps people from getting to the right level of care at the right time to achieve their maximum potential. And I think that's the challenge, right? So when you're advocating, tell us about how do we create solutions, right? Because so oftentimes when people throw their hands up in the air, it's because they're frustrated because the right level of care may not exist in their system. How do you introduce different levels of care and advocate for Medicaid systems or for licensing bodies to get involved and say, you know what, this is what's missing, and how do we add that in?
Boy, is that a big question. So I think how we do it is we start sharing the stories of what didn't work and then talk about opportunities of how it could work better. And that might be by sharing how something's happening in another state, right? It might be by saying, hey, we really do need this other level of care like IRSHs, right? The intensive residential service homes. That's the level of care my son's in now. That was introduced back in 2018 by the complex needs team. They compiled this group of stakeholders who came up with what would be the solutions for the people who were the most intensely sick, right? And then you get your stakeholder buy-in, you get the legislators to understand why you need that, and you go ahead and you start introducing legislation. It is a process to do that, but sharing models from other places that's a great way to try to help people to see that there's potential for improvement.
Yeah, and Leslie knows this, but there's just so much education that has to happen. And you have to do that in a really nonpartisan way. Because at first, when you get involved in politics, people are going to try to pick a side, but very quickly you can humanize behavioral health needs. And almost everybody knows somebody or has somebody in their family. And so if you start it there and start understanding that it's healthcare, it's not just mental health care, it's healthcare, and that everybody needs healthcare. And if we can get that understanding, then it's not as bad when you start talking about what do people need. And then what I did when I came in as a legislator, I mean, I was, I guess, the only person that really had my background the day I walked in. So what I did was just take people's calls from their constituents and just answered the calls. So, I just became helpful to anybody in the building who had calls they didn't know what to do with. And so I'd answer their emails, I'd answer their calls, and just help, because even the legislators who aren't in this field or specialize in this are like, we don't know what to do either. So I came in and said, well, I don't know everything, but I know a little bit more than probably you might. So let me help you with those. And then they helped me with all the farming stuff that Jason would know that I don't know. And so, that's that education and just kind of working together. And it's a very slow process. But I know, Leslie, you're talking about you as from yourself, but how did you transition from being that volunteer lobbyist to wanting to work at a center? What was that decision point for you? And then what do you get to do now that you're at the Treatment Advocacy Center? What do you get to do a little differently? And like, how has that work a little bit changed for you?
Yeah, so for them, I am doing tracking of legislation, like I said, across the country, but I'm working amongst people who are in the life like me, right? They all have a reason that they're there. They all most of them have a personal connection to somebody living with a very severe mental illness. And so we're very focused in on improving access to treatment on an outpatient basis. So one example of that is implementing assisted outpatient treatment. And that's how I got associated with the Treatment Advocacy Center in the first place, right? And so I'm going to not answer your question and switch over to that just because I said the words AOT. So that's a level of care that we did not have in Iowa.
Yes.
And so we improved the commitment law in 2018 and then began the work of stakeholder engagement, getting all the people that we needed on board, from a judge to the law enforcement, to the mental health providers, the hospitals, the substance use providers. And then, obtaining funding that we got from our MHDS region to start a pilot program and get that going. And that's the work that the Treatment Advocacy Center does. They have a whole AOT implementation team who helps a volunteer like me in the respective states to start those programs. They kind of help you along in understanding how that process works. That's one aspect of what the Treatment Advocacy Center does. Another thing that we do is we really do help states to improve legislation, improve commitment laws, so that it's easier to get somebody into the hospital when they really do need that level of care, while protecting their due process rights, but improving the laws so that you don't have to wait for somebody to become so sick that they're a danger to themselves or others, right? Because that isn't smart. The brain's much more sick by then. It takes longer to bring them back. But also it's exposing them to potential to either die by suicide or become criminalized, right? You're making dangerousness a requirement, so it's increasing the likelihood that something dangerous occurs. It doesn't make any medical sense. It doesn't make any public safety sense. And so that's something that we're doing, is helping them to improve the standards so that you can consider psychiatric deterioration, where if we do not step in, it's very likely that the person will deteriorate to the point that they're going to become dangerous to themselves or others. So that's another aspect. And then another part that the Treatment Advocacy Center is very involved with is research, supporting research, sharing research that applies to people with these most severe mental illnesses, which is a challenge because a lot of the research has not been done for this population for a number of reasons, but one reason is they undercount this population in the country. They have not counted people with SMI who are homeless or incarcerated. It's a huge portion, right? And so that's another thing that is really important to tack.
Wait, I wanted to comment on some things, Renee, and Leslie said so much, I had to take notes as we were going. Well, I
Right.
want to jump back because I just wanted to highlight, and I know we're not to the data portion yet, but there's some great resources that we're going to link in the show notes. And I really enjoyed reading that report on the involuntary commitment and the grade each state got, because I think it's really important because we have listeners from all over just to recognize how much variation there is. I started my career, Leslie, doing mobile crisis and facilitating involuntary committals when I was in Pennsylvania. I've also done that work in Iowa, and right now I'm in another state, and I just see how different the laws are interpreted, how even from region to region it's different, and how different that process is, and how frustrating that is for families who are trying to utilize those systems. And so if you're in a state and you're not sure how your state rates, I think that's a great place to start if you want to take a look at that and think about how you can help to advocate. Because certainly, until you work in this field and you kind of dig into those things, Leslie, I don't think you recognize that you'd kind of think those things would be kind of the same as you look across the country. However, they're so different. It's almost unbelievable sometimes.
Well, and I just thought about what you said about being underrepresented, and that we started off the whole show with the idea of that anosognosia, right? And so how in the world, if you're doing things like self-report or many types of research, and you're trying to work with people who don't even realize they're sick, they're not going to report. And I work now with parole and incarceration all the time, and I see these folks that I'm interviewing, and they've got these big time diagnoses, and they take zero medications, and somehow they think it's magically going to work on the outside. And I can't tell you how many lectures I give on the subject, because I'm like, this isn't adding up. It's like, these are all the things that were going on with you to get here. Now you're here, and now you're saying you're just going to walk out the door with nothing, and it's magically going to be better on the outside. And that is just such a state of mind where they're just like, well, yeah, it's all good. And I'm like, it's not good, And so having those conversations with people about the individualized treatment plan, and Leslie, this isn't on our list to talk about today, but I know you would think about this. One of the things Jason and I've talked about is individualized planning and how important that is, because sometimes we treat people like a category of people, and that happens with bed tracking as an example, but it doesn't work. People are not math equations. They're not algorithms, they're people, and it's not a straight line. So even in your son's case, I'm guessing there's been periods of time where things are better, things are worse, and they could all be in a relatively short time. So what are your thoughts on that, about the case planning that goes on and how we need to individualize it to a person and not a category?
Yeah, I so agree. There could be one person with schizophrenia, and you've seen one person with schizophrenia, right? They're all different. And the thing that I think that is really critically important is to understand that it's on a continuum. These are chronic, episodic illnesses. And so the needs change sometimes from day to day and sometimes year to year, depending upon how well somebody is doing and how stable they are. And so having intensive case management that takes that into account, and flexibility of funding their care to allow them, if they're doing well, go ahead and lower that level of care as long as they're able to stay stable. But hey, if they're starting to deteriorate, let's act now. Let's not wait until they end up getting so sick they have to go back in the hospital and then start all the way back over. And all too often, I think we have a slowness to intercede and maybe make a med adjustment or add a little bit extra level of care to help keep somebody stable, because their brain sustains more damage every time they go back into a psychosis. And the longer they're in psychosis, again, more brain damage. And it makes it much more difficult to get somebody to a higher functional level. And the thing is also is that some people are much more mildly effective. They're going to get a diagnosis of schizophrenia or bipolar. They're going to go through one or two bouts and they're going to stabilize. They're going to get the right meds sooner, figured out, and they're going to be able to function. I know people that are university professors who have those diagnoses and they're doing great. And they'll probably do great as long as their meds continue to keep them, stable and working. But I know other people like my son who he just has always needed 24/7 care. And I'm hoping that someday he'll get better enough where he won't need that level of care. But until he does, I don't want him to have to keep failing and deteriorating to qualify for the level of care he really needs.
Yeah. And that ties into sort of our next conversation is about housing that heals. And we've talked about that. And one of the downfalls in the insurance system, right, is they get stabilized at a level of care. And so they step them down. But the reason they were stable was because they were at that level of care, not because they were able to move down. And so when you think about housing that heals, what is your definition of that? And then what is different in that type of housing than, say, another type of supportive housing? What's different about housing that heals, Leslie?
Yeah. So there's some really good examples of housing that heals. There's a company called Synergy out in California where they have a residential facility, and then right next door is a separate outpatient mental health clinic. And so right next door, they have access to a psychiatrist, to a social worker, to the various professionals that they need. And it's not secure. They can come and go, but they're able to flex up the amount of support a person needs and flex down to a certain extent within that level of care. And that's really helpful. And what I like about that type of a facility is they have community. They do some things together, but they also have privacy, right? They can have their own personal bedroom. They can have their own meals. It's much more of a community setting that's comfortable, but doesn't feel like being locked into a state hospital, for instance. And, housing that heals can be anything from a regular old HAB home like we have here in Iowa to a higher level of a HAB home like the Urshus, where my son is, and they do have 2 people on staff for 24/7 staffing. It could also be an apartment with some community supports. Housing that heals isn't a one size fits all type of facility. It is having the ability to have a variety of different things, different options available so that you can funnel the right person into the right level of care.
It seems like a no-brainer to offer the right level of treatment at the right time to someone in a timely manner would just make sense. And so why is our system struggle so much to adapt to being able to align what someone needs at the moment to what they need, right? That was a horrible way of articulating that question.
I
But I
understand
hear
what you're
this
saying.
so often when I'm traveling around, that so often the answer is they're really difficult to treat, so they just need to go to the state hospital because there's no alternative. So how do we introduce these alternatives so that we can figure out who would best respond in that setting? Because I think you have some thoughts on kind of what array of services we need to have to meet everybody's needs, right, Leslie?
Right. So I think part of our struggle with it right now is that we have too few beds in each of those types of placements, right? We don't have enough beds, and there's a fair amount of cherry picking that goes on in some of these placements to have the people that are the easiest to take care of. And, that's human nature. That tends to happen. So I think it's partially that, and the fact that we're not paying people enough to take care of the people who are the sickest. And it does take time to build out systems like the IRSH beds, for instance. We're supposed to have 120 of them. I think 2 years ago, we were supposed to have 120 of them.
Yep.
And I just got updated numbers yesterday. We have 35 currently, and by August, we should have 66, which is wonderful that more are in development, but it's still half of what we're supposed to have, right? If those numbers are right. And time has gone by, so it might be even more. And the problem is that they have waiting lists. And actually, an IRSH level doesn't maintain a waiting list. The social worker at the MHI had to keep sending out the application in hopes that it would arrive when there was an opening. They wouldn't keep a waiting list. So all of that is very difficult. And the other part of it is that if somebody is difficult to care for, they get blacklisted. One level of care will not take them back, or a certain facility will not take them back, even though the reason they got blacklisted is probably because they were undertreated for their illness at the time that they were there, and their status may be completely changed. So all of those things happen. And the other piece I'll talk on is that insurance companies tend to think that somebody's going to go from being in psychosis and they're going to progress to being completely normal. And that isn't the reality for everyone. Boy, do I wish it was. But that isn't the reality, right? And so that touches back to what you were saying, Renee, is that, the insurance company always wants to be lowering that level of care. Well, not everybody's going to do okay with a lowered level of care. And maybe it's okay to listen to the treating providers and their recommendations.
100% agree. 100%. Because that gets really frustrating. Like I said, they stabilize at a level, and then instead. But I'm really excited about housing that heals, the whole concept of that, because it is what we just talked about being individualized for the person, right? And some people's diagnoses, they can't really live with others because of a diagnosis. And then other people's need others around for some social supports. And so you can't just put them all in the same shape box and expect it to work. And it may not be the same over their lifetime, just like you said, right? There might be parts of time where living it completely independently is a good idea. And then other times they need to live with social. So it's not a one size fits all for one time forever. So that's really exciting that you're talking about that. Jason, we had some other data you wanted to talk about. Is there anything specific in the data, or you just wanted to talk about it being in the show notes?
Well, we didn't talk about some of the things I had data pulled on. So, I think Leslie sometimes talks to us about the need for beds in the state of Iowa. I've heard you talk a lot about the need for more beds. And really, you're usually talking about institutional beds, that we do need more institutional beds than we have, which goes counter sometimes to what we think. And, even some of the things I've said in other states that, well, maybe it's not the beds, maybe it's how we use the beds. But why don't you tell us your thoughts on needing more beds, Leslie?
I will, but before I go on, I just want to make one point. For Housing That Heals, the people that coined that term were two moms in California, Teresa Pasquini and Lauren Battagliata. They literally drove all over California looking at all the different types of housing that heals and wrote a white paper on it. So I just want to give them credit for that term.
That's awesome. Thank you for that.
Yeah.
We'll have to look it up and attach it to the
Yep.
show notes. That'd be cool.
Absolutely. So back to your question, Jason. Yes, we need more state beds. In Iowa, we are ranked 51st in the country. We only have 2 per 100,000 people, and per TAC and the American Psychiatric Association, we should have 50 per 100,000 people. So we are severely underbedded. And the reason I fiercely believe we need more beds there is not because I want people to go and live for the rest of their lives there. But the reality is that at acute care hospitals, people are not getting the length of stay that they need, nor the multidisciplinary approach with comprehensive treatment that they need in an acute care hospital. So for the part of the population who really needs to have regular interaction with a psychologist, exercise, whole body healthcare, right? They caught my son up with dental care, with vision care, with internal medicine care. That type of care doesn't happen in our acute care hospitals, and nobody's brain gets stabilized for a psychosis in 72 hours or even in 2 weeks. It takes a lot longer than that. And so having some more state hospital beds where somebody can have an extended period of time, or even if you were to create a new level of care and create a new little hospital that did this for an extended period of time, that would open up beds everywhere, because we see right now that a lot of people are boarded in inpatient beds, especially at the University of Iowa, some for up to a year. Why? Because there's no housing that heals to receive them, right? We don't have that long-term care that they really need. And so somebody new presenting in psychosis, they can't get a bed, right? At all backlogs. And so having a more robust system at every level of care allows for that mobilization through the system. But more importantly, it helps the people get the care that they need and their brains to heal.
Right.
Yeah, and so I did link that Des Moines Register article where they highlighted exactly what Leslie is talking to us about. And I also threw in there, if you're a nerd like me, the National Library of Medicine has a great article about how hard it is to predict. And there's really not a standardized analytical model for how many beds a state needs because it's so hard to measure. So we kind of talked about the data, right? We always question data, on this podcast. And so that's a great read as well, because, Renee and I have been called into states and asked, how many beds do we need? Right now I'm in a state and they're asking, the legislature is asking me the question, how many beds do we need? And it's not an easy answer. As you can see, this conversation today kind of helps us better understand that you just can't go in and say you need 150 beds of this and 50 beds of this and 75 beds of this, because it's not that easy. We wish it were, though, because these are the types of things that it's really hard to come up with solutions. And there's lots of people with opinions and there's lots of reports, but we need to be able to take all that information in and understand it. And I think that's really hard sometimes. That's why, we like to have these conversations, because it helps us to look at all sides of the issue and then come up with solutions so that we can better meet the need than we are today.
Yeah, well, as we are winding down today, I'm going to throw in my recovering politician self-care tip for the week. It's my favorite time of the year. We're in summer and we just hit Memorial Day weekend, and that means the swimming pool is open outdoors. And for me, that means I'm going to be sitting by a pool or the ocean with my laptop, pretending like I can see my laptop and not really working. And I do this often. And when they say I can work remote, remote could be anywhere, people, just so you know, but you got to take advantage of it. So what about things that, just think about what you can't really do, especially if you're in the Midwest like us, the rest of the year that you can do starting in May. And that's what I get excited about. So for me, it's out in the sun, out by the pool, out with my bike, all of those things. Jason, what about you for self-care when it comes summer, when you hit the time? What are you doing for fun?
Well, I've had to look at my calendar this summer because while you're at the ocean, some of us are on the speaking circuit. And so I actually looked at my calendar. There's actually 1 week that I go from Iowa to Illinois to Nebraska within 3 days. I don't know who does my scheduling, but I'm having to think a little bit about predicting of what do I need to do to take care of myself, right? Because it's fun. I enjoy that. It re-energizes me to go and do those conferences. But I need to take some steps, right? I need to do some things to take care of myself so I can be at my best. So I'm thinking about, different places I can stop, maybe get a hike in, build in some restaurant stops and, different stops that I want to hit because I enjoy traveling as well. I enjoy the long drives, as I wave at my house as I drive right by on the interstate to keep going to make the time frames. But, I think even when you're busy, you can create fun and you have to find those ways to recharge and regenerate. And I won't be at all mad at you, Renee, for being on the beach while I am out working, carrying on the brand of Rural Policy Partners.
Yeah,
Leslie, what are you doing to recharge
just
this? Because
keep
I
it
know
up,
you're
Jason.
you're,
Keep it
you're
up.
always busy, Leslie. So tell us what you do.
Well, what I haven't done yet, but I'm desperate to do is to go kayaking. That is my piece, is to get out on the water. And I'm hoping to get there on Sunday. That is my plan. That is what I'm going to be working towards. And I love summer because it allows a lot more time to do that.
That's awesome. Thank you. And for all of you that are feeling sorry for Jason, just don't, because I'm having to speak right next to him at most of these occasions. He failed to mention that. Well, today we are very grateful that Leslie Carpenter joined us. And so thank you so much for being here, Leslie. And before we end the program, is there anything that you just want to leave people, a thought, an idea, something that you want people to think about as you wind up your time with us today?
Yeah, and I apologize. It's going to be more to content than you thought. What I really did want to also talk about is assisted outpatient treatment and how having a judge involved and a case manager working to oversee that the patient stays engaged in treatment, but also that the treatment system stays engaged with the patient. What we do see is a huge reduction in repeated hospitalizations, reduced homelessness, reduced arrests. It is one of the options to do and to implement in states where you don't have enough beds, because we can serve some of these people on an outpatient basis, and having that oversight with the court really helps to improve the accountability for everybody involved and the effectiveness.
I love that. And I can just tell, I don't know about you, Jason, but I think we need to have Leslie back again. We're going to have to do some deep dives just on some of these topics, because we could talk on each one of these topics for an entire episode or two.
I think we're going to be recommending implementing assisted outpatient treatment here in the near future. So I think we need a whole episode dedicated to assisted outpatient treatment at a minimum coming up, Renee.
I agree. I agree. Well, thanks everybody for listening today. If you heard anything we talked about today, it's for everything from assisted outpatient treatment to talking about decriminalization some, and talking about housing that heals, and talking about the folks that we get overlooked in the community that need help, but maybe don't even know they need help. And so thanks so much for our guest, Leslie Carpenter. Thanks again for everybody listening. We'll see you again next time. Have a great day, everybody.